Good morning, everybody. Thank you, Dr. Abhishek and Dr. Rath, for inviting me to this meeting, and congratulations for setting up Indian Society of Clinical Oncology, which I think is very much needed in India, because I think we all have to work together, medical oncologists and clinical oncologists. I would like to say that gynecological cancers is not my area of expertise. I specialize in breast and HPV cancers, but I am passionate about prevention of cancer, especially in low-income group and middle-income group countries. So I felt that I would feel very comfortable in delivering this talk, because I've been involved in villages in UP and Rajasthan and Punjab and Haryana during my 6-year stint when I was here a couple of years ago in prevention mainly of cervical cancer. So prevention of gynae cancers mainly relates to screening and HPV vaccination, screening for cervical cancer and also for high-risk BRCA positive women, where bilateral salpingo-oophorectomy and monitoring of possibility of developing ovarian cancer with CA125 and transvaginal ultrasounds is part of the screening methodology, which I won't discuss today, but I will focus on cervical cancers. Population-based screening, even though we have an amazing PBCR, we have a population-based cancer registry and a hospital-based cancer registry run by ICMR, which is doing a fantastic job, but we still do not have a population-based screening in India, and which is very much needed for common cancers. It's non-existent, mainly because of competing healthcare priorities like maternal and infant mortality, infections, insufficient resources, and limited trained providers. We know that if you look at this slide, you have VIA, cytologic testing, HPV testing, and the control group. And you can see that HPV testing, which is one of the most important causative organisms of cervical cancer, reduces the risk of cervical cancer-related death. So I will talk about how a point-of-care HPV testing is important, especially in rural India, where cervical cancer is very common, as Dr. Rath explained. In urban India, it's breast cancer, which is quite common. 1 in 7 women in rural India are likely to develop cervical cancer. If you look at the two methodologies, HPV versus PAP testing, there was pooled randomized control data of a huge number of women aged 20 to 64 years from 4 countries. These are 4 randomized control trials, and the data has been pooled in this paper published in Lancet 4 years ago. The study was done in Sweden, Italy, Netherlands, and UK. And the conclusion was that HPV-based screening provides 60 to 70% greater protection against invasive cervical cancer. And this is reflected in these slides. In all randomized women, you can see the experimental arm, which is the HPV testing arm. The cumulative detection rate of cervical cancer was significantly higher. And also with the women with a negative test at entry, this detection rate was significantly higher. And the follow-up on this study was about 6.5 years. If you look at the acetic acid, which is being done, and this study was published in JNCI a few years ago and was presented as a plenary at ASCO by Dr. Shastri from Tata Hospital. You can see that the cervical cancer incidence is going up. The study was done in Mumbai, and the cervical cancer-related death in ladies who had VIA plus education versus ladies who only had education was significantly better with VIA. But the issues with VIA, which I have faced myself in the villages, is trained personnel, is what looks white and what doesn't look white, and it needs a lot of training for all the healthcare workers. You don't have to be a doctor or a nurse to be trained into interpreting a VIA test, but you have to be able to interpret the level of whiteness. I don't have time to go into it today. So it's quite subjective. compared to an HPV test, which is a numerical test, and it's easier to interpret. Coming on to the HPV vaccines, there are various HPV vaccines which are available. It was licensed by FDA in 2006. And some of the states in India, like Delhi, Tamil Nadu, I think Karnataka, and Meghalaya have had a pact with Gavi, where they have implemented the HPV vaccination program for prevention of cervical cancer. But it is not implemented nationally. But again, I think amazing work is being done by NCIPR and ICMR in this. As you can see in this paper, with the introduction of that pink line is the introduction of the vaccine, there is a decline in incidence of precancerous lesions mainly in the age group less than 20 years. But in all the age groups, there is a decline in the incidence of precancerous lesions, which is where the vaccine helps us. The reason why this has not been implemented, and I think you will hear more talks about screening and vaccination in the morning session as well, which will be more detailed, is the claims have been that they do not prevent cervical cancer. Yes, it is true, but they have been shown to prevent PAP-detected precancers, which will ultimately lead to the cancerous lesions. So either the HPV vaccines work to prevent cervical cancer or they do not, but I strongly feel that they do. And one of the other things is that they cause serious adverse events, and again, there is no epidemiological evidence or biological rationale for this to be true. And so there are actually quite a lot of myths and things that have been promoted by misinformation by the media. If you look at the adverse events, if you compare the HPV vaccination with cervical cancer, every vaccine has every drug has a side effect. If you take paracetamol, it can cause fulminant liver failure and you can die. But we take paracetamol. Similarly, HPV vaccination or any vaccine will have some sort of side effects. But if you look at the adverse events with cervical cancer, you have all of these effects which are proven: death, loss of fertility, surgically induced menopause, and quite a few others. But with vaccination, these adverse events are quite rare. It's more than 1 in 50,000, the incidence of adverse events. The organizations that have approved HPV vaccination are NHS UK. All the children in school, the girls and now some of the boys in school as well, are vaccinated if they are above 9 years old. It's licensed for between 9 to 23 years of age. FDA, EMEA, the National Advisory Committee on Immunization in Canada, again, so on WHO, Australia, and US. The kids get the vaccination in the schools. So the rollout of HPV vaccination in low-income countries, there is data to show that 1 dose may be as good as 3 doses, or 2 doses may also be as good as 3 doses from the study published by Tata Hospital. I would like you to look at this link later on and the WHO guidelines, where they actually prefer HPV testing to VIA testing. But if you do not have HPV testing, then VIA testing should be done. There's a logarithm as to how it should be followed, and anywhere where screening includes any of these testing methods, the patients should also have access to colposcopy and LEDs. Again, there are a lot of eminent gynecologists in the audience who would be able to talk to you more about that. The key barriers to care for prevention I've seen in low-income group countries, mainly in India, have been capacity and infrastructure, the availability of the surgeons and gynecologists to do the test. The pathology is the major limiting factor, especially if you're doing pap smears. That's why VIA to us is very attractive, because at the same point you can say whether the patient needs any further treatment. Access to radiotherapy, and the key point that leads to the barriers in care is misinformation. This misinformation also applies to a country like UK, because I gave a lecture at Neasden Temple quite a while ago to about 300 mainly Gujarati ladies. And even though the cervical cancer screening, the mammography screening is free for them, as soon as a woman reaches 50 years, she gets a letter to have a mammogram. And they get free pap smear tests from the age of 23 onwards every 3 years. And what we found out that the pickup rate of screening was the lowest in this Asian population. And when I spoke to them, and there were these myths that the test itself will cause cancer, will cause a sexually transmitted disease. So all of these interactions, it is our job as doctors, and I think Dr. Rath and the team here are doing a fantastic job in increasing the education and awareness level in the villages, which is very important. I think all of us have a duty to do that. So I started this charity when I came to India in 2009, and I was involved with education and training of ASHA and Anganwadi workers after doing a knowledge, attitude, and practice analysis. And we found out that there was lack of sexual hygiene, the use of sanitary pads and all those things. So I had some people in the government in UP who helped me, including my uncle. And we made these toilets in the villages. And I recently visited them. The toilets are being used as storerooms now. And the ladies are still going in the fields and still not using sanitary pads, even though we provided some indigenous made sanitary napkins. So I think we still, by just, like what I did was I just went there once or twice and then, forgot about it and moved around to Bombay, Bangalore. I think it's important that if we take up a task, we have to persevere at it and keep going at it. Because I think once you give the education and you leave, the whole thing actually dissipates. So it's important that we continue the initiative that we have undertaken. In schools, I did HPV vaccinations. I started with international schools because it was easier to talk to them. I talked to at parent-teachers meeting, I talked to the parents, and that's how we implemented in some schools in Delhi and Bangalore. And slowly we started with the Indian schools as well, because once they see the data and disregard the misinformation that is propagated by the media, most of them are actually quite logical and want the kids to be vaccinated. The NICPR is also doing a great job, a body of ICMR. They are doing health promotion clinics with pap smears, VIA, and high-risk HPV testing by hybrid capture 2. And they have outreach screening camps as well. They're also doing virtual training, which I was very impressed with, by extension for community healthcare outcomes model. And if any of you want to get involved with that, I think that's excellent. It's very important that we should try and get at least one high-quality screen. The first screen is the most effective, hence it is cost-effective. And the Global Coalition Against Cervical Cancer, they have this one campaign where the campaign is that all women deserve at least one high-quality preventive or curative service against cervical cancer in their lifetime. And the younger women where the cervical transformation zone is more visible is easier to sample. So I think it's very important that all of us as a body focus on prevention of cervical cancer. And already, as you saw, Dr. Rath showed that the incidence of cervical cancer is going down, but still you will have 1 lakh women who will develop cervical cancer. So we've had polio eradication by the vaccine. Nobody has polio. I think that's what we should aim for. We should have no cervical cancer in India. Thank you.